Assalamu alaikum colleagues. Welcome back to Pete's Mentor. I am Dr. Atif Raza, and today we are tackling the single most time critical neurological emergency in neonatology, that is approach to neonatal encephalopathy along with hypoxic-ischemic encephalopathy, that is HIE, and their management as therapeutic hypothermia. So as usual, I am starting this lecture with a scenario. Imagine you are the senior resident. You get a crash call to labor and delivery. A 39-week infant is born via emergency C section for prolonged fetal bradycardia. So, here is a scenario: 39-week infant is delivered via C section, which is due to an emergency due to prolonged fetal bradycardia. The baby comes out limp, pale, and apneic. Baby was limp, pale, and apneic. You start resuscitation. You intubate the child. By 10 minutes, the heart rate is greater than 100, but the baby has no respiratory drive and is completely hypotonic. So, after the resuscitation of this neonate, heart rate increases above 100 beats per minute, but the neonate is hypotonic. The obstetrician looks at you and asks, "Doctor, is this baby going to be okay?" The nurse asks, "Should I turn off the warmer?" Now, your decision in the next 6 hours will determine if this child walk, talk and goes to school or faces a lifetime of severe disability. So, today we are mastering neonatal encephalopathy. So, this lecture is all about mastering HIE and therapeutic hypothermia. I am going to teach you the 2025 approach, the exact criteria to start cooling, the bedside management pulse using the care mnemonic, and how to dodge the classic board exam traps. So, here in this lecture, we will discuss the 2025 approach, the exact criteria to start cooling, the bedside management using a mnemonic, which is here, and the board exam traps. So, stick with me till the last of this lecture so that you can have a comprehensive knowledge about how to manage this child. So, starting with the definition, here is a trap. Neonatal encephalopathy is a broad term, and hypoxic ischemic encephalopathy is one of the part of neonatal encephalopathy. So, neonatal encephalopathy, this one, is a clinical description. It is not a diagnosis. It simply means a baby which is 35 week or more having abnormal consciousness level, abnormal tone or seizure. And the hypoxic ischemic encephalopathy is a specific subset of neonatal encephalopathy which is caused by lack of oxygen and perfusion. So it is specific for all those who faces the ischemic crisis or hypoxic crisis. So this is due to lack of oxygen and perfusion. So remember, not all NE is HIE. If a baby is encephalopathic but has a normal pH, normal base deficit and no sentinel event, stop. Do not cool immediately. You must rule out the mimics. So remember, There are some mimics of HIE which do not fit into the cooling criteria. So you have to rule out that mimics first. Mimics are, for example, metabolic, which might include urea cycle defect. So you have to check ammonia. It might be due to molybdenum cofactor deficiency. So here in this, you should look for lens dislocation, non-ketotic hyperglycemia, which might have hiccups in utero. Mimics might be infectious, which includes meningitis, encephalitis caused by HSV enterovirus GBS. Hair cooling worsens coagulopathy. The third one is trauma, which might result in subgleal hemorrhage. So look at the boggy scalp. These babies are encephalopathic from shock, not necessarily primary brain asphyxia. Might be due to neuromuscular, which have spinal muscular atrophy type 0 or 1. These babies are alert but flaccid. They have the bright eyes sign. But hypoxic-ischemic encephalopathic babies are not alert if they are flaccid. And one other mimic is stroke. Perinatal arterial ischemic stroke often presents with focal seizures rather than global coma. So, before labeling any child having HIE, you should rule out the mimics, which includes the metabolic, infectious, trauma, neuromuscular, or stroke. But if the diagnosis is unclear, start cooling. So remember, if you are not having a definitive diagnosis, that is, you have a unclear diagnosis, you should start cooling. But remember, it is safer to cool and rewarm early if you find a cause other than HI than to miss the window. So, if the diagnosis is not clear, you should start cooling and send labs for metabolic, infectious, and other causes to rule out. It is safer to cool and rewarm early than to miss the window. But draw your labs, that is ammonia, lactate, blood culture, coagulation profile before the temperature drops. If you find a cause, then you can rewarm the child. But if you miss this opportunity, you can let the child for a substantial mortality. The window for cooling is very narrow. This is just for 6 hours from the birth, that is 0 to 6 hour. So you have this narrow window for HI to start therapeutic hypothermia, that is the cooling process. Why is this limit for 6 hours? Why we can't cool at 12 hours? Because it comes down to energy failure. Where a baby delivers at birth and having an insult, that is hypoxia. So hypoxia leads to anaerobic metabolism. Because of this, lactates build up, pumps fails and cell die. This damage is done. We cannot fix it. So we have a very narrow therapeutic window for cooling because of Energy failure. Energy failure is of two types. First one, which is due to insult, is primary energy failure. So, in primary energy failure, which occur at birth and result in any insult which results in hypoxia, this hypoxia leads to anaerobic metabolism. This anaerobic metabolism leads to ATP depletion. This ATP depletion leads to pump failure, that is the sodium potassium pump, and this failure results in cytotoxic edema and the cell death. So, if you left this child, then this can lead to secondary energy failure and that was lethal. But if you resuscitate the baby, blood flow returns, the brain metabolism temporarily recovers. The baby might even looks up better. Now this is your window. That is the 0 to 6 hour. This insult have occurred. You cannot reverse it. But at the window period, that is the 0 to 6 hour, you have done your resuscitation, that is the NRP, blood flow retains. So the brain metabolism recovering temporarily. So you have to act over this period. You have to make decision because the look of the baby at this stage is the trap. This is because inside the neuron a time bomb is ticking. If you don't cool, the excitotoxicity cascade begins. So if you do not cool baby in this period, that is the 0 to 6 hour, this can lead to secondary energy failure, which is due to excitotoxicity cascade. In this cascade, we have an excitotoxicity neurotransmitter, that is the glutamate. With the release of massive glutamate, it activates NMDA receptors, resulting in massive influx of calcium inside the cell. So, if you do not cool these babies in this window, glutamate level rises, resulting in overexcitation of NMDA receptors, resulting in increase or massive flow of calcium inside the cell, which results in activation of proteases inside the cell. So, proteases activation increases, and this result in cell engulfing process, that is the apoptosis. So, this is the primary energy failure, and this one is the secondary energy failure. If you cool at this window period, the metabolism, the brain metabolism slows down. Cooling effectively freezes this cascade. For every 1 degree centigrade, cerebral metabolism drops by 5 to 7%. So we are buying time for the brain to heal without triggering the suicide program. So we have to act efficiently and in emergency so that we can decide whether this baby fulfill the criteria for cooling or not. So let's start with the cooling criteria. We are following the standard international criteria for cooling. In cooling criteria, we have few points, that is the age of the baby, that is the gestational age, The baby gestational age should be 36 week or more, and weight should be greater than or equal to 1.8 kg. In some protocols, it is 2.0 kg, but for boards, stick to 1.8 kilogram. There is a gray zone as well, that is the 35 week. Can we cool this gray zone, that is a 35 weeker? So the question arises, can you cool a 35 weeker? At some centers, 35 weekers can qualify for cooling if they are large, that is greater than 1.8 kg, and physiologically mature. But remember, this is off label. So here, some centers are following off label cooling if they are looking bigger and greater than 1.8 kg, because it increases risk of IVH. This is the criteria which is essential for all babies to meet. Now we have some objective asphyxia, that is the labs values which is required. We at least need one of them, that is either the pH or the base deficit. pH should be less than or equal to 7.0, and base deficit should be greater than and equal to 16 millimole per liter. But there is a borderline clause. If pH is greater than 7.0, that is 7.01 till 7.15, or base deficit is in between 10 to 15.9, you can still cool if there is a sentinel event. So if pH is in between 7.01 and to 7.15, or base deficit 10 to 15.9, but the child have a sentinel event, that is uterine rupture, cord prolapse, and placental abruption, and Apgar score of the neonate is less than or equal to 5 at 10 minutes, or baby require ventilation for more than or equal to 10 minutes. So this one cooling criteria, those child having gestational age greater than or equal to 36 week, weight greater than or equal to 1.8, having pH less than or equal to 7, base deficit or base deficit less than greater than or equal to 16 millimole per liter, can qualify for cooling criteria, but we should have exam criteria, that is criteria based on Sarnat modified exam. We have exam criteria, that is Sarnat exam, which must be in the category of moderate or severe. So here we use the modified Sarnat exam. You must assess 6 domains. First one is LOC, second one is tone, third one is reflexes, and we divide it into mild, moderate, and severe. For mild, level of consciousness of the neonate would be hyper alert. For moderate, child should be lethargic, and for the severe, it should be in coma or stupor. For tone, in mild, tone would be normal or jittery. In moderate, tone would be hypotonic, that is a frog leg posture. and is severe, it should be flaccid. For reflexes, mild have hyperreflexia, moderate have weak sucking or motor reflex, and the severe have absent reflexes. You have to examine pupils as well. In mild, pupils are dilated. In moderate, it is constricted, and in severe, it is fixed or dilated. Seizures. In mild, there is no seizure. Moderate have seizures, and here in severe, it is rare. Based on this, we have few decisions. That is, let's suppose this is A and this one is B. If the child is meeting criteria A along with criteria B falling in moderate to severe, you have to cool this neonate. If you detect seizures at any stage within the 6 hour, either clinical or amplitude integrated EEG, you should cool the baby. So, for cooling criteria, the baby must fit in this criteria first, that is the gestational age and the weight criteria. Then you need one from the objective asphyxia, that is the cord pH or the pH of blood within 1 hour, a base deficit. This is a borderline clause. So, if a child is meeting either pH or base deficit criteria or the borderline clause along with moderate to severe clinical examination findings, so you have to cool that baby, and the cooling should start within the 6 hour. Let's suppose if I ask you a question, a baby has a pH of 6.9 but is alert, active, and sucking on a pacifier at 1 hour of life. Do you cool? Answer this question following this criteria. The baby is alert, sucking, and having activity. So it falls in Sarnat exam criteria mild, that is stage 1. So if one of the criteria is not met for cooling, you should not cool that baby. So here should be the answer, you should not cool the baby. There is a controversy, that is mild HI, that is this one. So you should also have a sound knowledge about this. If a baby falls during your examination in mild HIE, you should not cool that baby. However, recent data suggests some mild babies have adverse cognitive outcomes. So, based on this data, we do not routinely cool mild HI, but you have to admit these babies to NICU and you have to perform serial Sarnat exam every hour for 6 hours. If they drift to moderate, that is, their tone drops, they become lethargic, you should start cooling immediately. So, for mild HI, you should not send this neonate to ward, you should examine in NICU for 6 hours of life, that is from 0 to 6 hours. If any of the criteria, examination criteria shifted and fits in moderate, you should start cooling that baby. So up till now you have a sound knowledge when to say yes for cooling. Now I am proceeding this lecture when to say no. That is the contraindication for cooling criteria. So what are the contraindications? There are several contraindications. Let's suppose if the baby has no heart rate for greater than 20 minutes and severe refractory hypertension, cooling may just prolong the death. This is a difficult ethical decision, but you have to make it. So, all the moribund infants, which requires greater resuscitation time and still having no heart rate or having hypotension, you should not cool these babies. Those babies which have major congenital anomalies such as trisomy 13 or 18, having gastroschisis or exophthalmos. This is a relative contraindication because cooling reduces gut perfusion, which can lead to bowel ischemia. So, gastroschisis and exomphalus, imperforate anus. This is because you can't put a rectal probe. So, we should use an esophageal probe here. Diaphragmatic hernia. This is also a relative contraindication because in this neonate, PPHN is the main killer and cooling may worsen PPHN. And those neonate which are having severe bleeding, because hypothermia causes platelet dysfunction and coagulopathy. So you have to manage this first. Give FFPs, platelets, cryo. Once stable, you can cool, but you must keep INR less than 1.5 and platelets greater than 100 K. So here are some contraindications. Number one is moribund infants, that is resuscitate for greater than 20 minutes but still have no heart or having severe hypertension. Major congenital anomalies, for example, trisomy 13 and 18, gastroschisis or exomphalus, diaphragmatic hernia. Gastroschisis and exophilus are relative contraindication due to risk of bowel ischemia. Severe bleeding is also a relative contraindication. You have to fix this first and keep INR less than 1.5 and platelet greater than 100 K to start cooling. Now, we come to the management protocol, that is using a care mnemonic. Here C is used for carbon dioxide and cardiac. You should keep the target of carbon dioxide 40 to 50 millimeter of mercury because hypocapnia is dangerous. So keep in between 40 to 50 millimeter of mercury. And cardiac rhythms, while we cool these infants, we should expect heart rate in between 40 to 50 beats per minute. Do not treat this. You should know this is a physiological response to cold and prolongs diastole, which is good for coronary filling. One more thing, cooling causes peripheral vasoconstriction. That is, it increases SVR but decreases contractility, which can lead to hypotension. So, you should expect sinus bradycardia and we should not treat it. Heart rate is in between 40 to 50 beats per minute. And there is hypotension. And for hypotension, we use dobutamine to treat rather than just dopamine. A is for antibiotics. Cooling suppresses fever. You will lose your febrile response to sepsis. So, you should start antibiotics. That is the ampicillin and gentamicin. R is for renal and restrictions. That is fluid. You should start fluid at 40 to 60 ml per kg per day. Why we are starting at this level? Because the hypoxic brain dumps ADH, which results in SIADH. It can result to ATN because of ischemia. You should also watch for electrolytes because SIADH can cause hyponatremia. So you should watch for hyponatremia, which is due to SIADH, and hyperkalemia, which might be due to cell necrosis occurring due to acute tubular necrosis. So C is for carbon dioxide and cardiac rhythms. A is for antibiotics. We give ampicillin or gentamicin. R is for renal and restrictions. That is the fluid and electrolytes. And E is for electricity. That is seizures and shivering. We will discuss seizures later on in detail. For shivering, why we should note any shivering event? Because it is bad for the process of hypothermia because it increases metabolic rate. We should avoid shivering. So we have to give Presidex, that is dexmedetomidine, which is the drug of choice. So we treat shivering with Presidex. Or second line is clonidine or morphine in low dose. The last resort is neuromuscular blockade. You should avoid if possible because it masks seizures. Important point to note over here, therapeutic hypothermia can worsen pulmonary hypertension by increasing pulmonary vascular resistance. So you should monitor pre and post ductal saturation and oxygenation index closely during cooling. So remember one thing, cooling can worsen PPHN. So you should monitor pre and post ductal saturation along with oxygenation index. Now come to the seizure management. 50% of HIE babies have seizures and 70% of those are subclinical. So HI babies having seizures, but importantly, out of this 70% are subclinical. That is, you cannot detect by own examination. So you have to use amplitude integrated EEG to detect those seizures. So these are detected on amplitude integrated EEG. So we should use uh, aEEG within the 6 hours so that you can detect those subclinical seizures. On aEEG, there are few patterns, the normal one, the bad one, and the worst one. Normal having the continuous voltage just like this. Bad one have a burst suppression pattern that is just like this, and very bad, that is the worst one, having a isoelectric line. And for the seizures, there is sawtooth pattern. So for seizures, you should look for amplitude integrated EEG, and you know what the pattern looks like, so that you can detect seizure and the other normal values. For the seizure management, the drug of choice is phenobarb. So for seizure, first line is phenobarbital, which can be given 20 mg per kg IV. But remember, high doses causes respiratory suppression and hypotension. Here, the second line is fosphenytoin or levetiracetam, that is the Capra. Capra having the safe cardiac profile, so it is preferred in some units. Fosphenytoin have the risk of cardiac arrhythmia, so it should be given under the EKG monitoring. Third line is for refractory seizures, which includes midazolam infusion and the lidocaine infusion. Lidocaine infusion have a contraindication, so you have to remember this contraindication as well. If you are giving lidocaine and the baby is on phenytoin, there is a contraindication. Do not use lidocaine if the baby is on phenytoin because of cardiac toxicity synergy. And if the baby is having congenital heart disease, you should also not use it. So, for a safety profile, do not start lidocaine without consultant cardiology or neurology approval. So, there are some contraindication, that is child having congenital heart disease or on already on phenytoin. So, you should only use lidocaine after consultant approval. I have a question for you. Let's suppose a baby is jittery. How can you identify that the child is having seizures or this is just a jitterness? So, to distinguish in between these two, you should hold the limb of the neonate. If the shaking stops, it is jitterness. So, jitterness stops while holding the limbs, but seizure do not. So, after the seizure management, we have the imaging protocol. You might encounter those parents which will beg you for an MRI on day 2 to know the prognosis. But you must know why to say no at this moment. So at day 2, you should not order MRI because this is a phase which we called as pseudo-normalization. What is pseudo-normalization? Between day 2 and 4, cellular edema can make the T1 T2 sequence look falsely normal. So if you look at day 2, you can give a false hope to the parent. So the golden window for the MRI is in between 5 to 7 days. So you should order MRI T1 T2 sequence at day 5 to 7. Before this, you can order diffuse weighted imaging because it is great for early injury, But T1, T2 at day 5 to 7 give the best prognostic anatomical detail. So you should order MRI at 5 to 7 days, which is T1 and T2. There is another, that is MRS spectroscopy, which looks at the lactate peak. If you see a lactate peak, if you see a lactate peak on day 7 in basal ganglia, this is a poor prognostic sign. So at day 7, if you see high lactate level in basal ganglia, this is a poor prognostic sign. What we look at MRI, we should look for two types of energy, that is the basal ganglia thalamus injury or the watershed injury. So you have two types of injury, that is basal ganglia thalamic injury, which results due to acute profound events, that is cord prolapse or uterine rupture. And this injury predicts motor deficit, that is the cerebral palsy. So if you found basal ganglia or thalamic injury, it results in motor deficit and the child might have cerebral palsy. The second is watershed injury. It occurs due to prolonged partial events, that is the placental insufficiency, and it results in cognitive deficit, that is the child might have school problems. So for imaging protocol, best and gold standard best and gold standard is MRI at day 5 to 7, and MRI is T1 T2, but you can order diffuse weighted as well before this, and spectroscopy as well to detect lactate level at basal ganglia. You can also do cranial ultrasound, but this is to rule out other causes. This is good for intraventricular hemorrhage or to detect ventricular size, but this is bad for HIE cortical injury. So it is good for IVH. Now you have managed a lot of things over here. Now come to the last topic of this lecture, that is the therapeutic hypothermia, its duration, its exact temperature, and when and how to start rewarming. So you start cooling the baby. You should maintain the rectal temperature in between 33.5 degrees centigrade plus minus zero point 0.5 degrees centigrade. You should keep the temperature exactly in between, not 32, not 35. So for therapeutic hypothermia, the exact temperature you need is 33.5 degrees centigrade, and the duration is for 72 hours. So you should strictly follow these two rules. If you are transporting any unit, you should use passive cooling, but remember ice packs should never be used as they risk uncontrolled overcooling and skin injury. So during transport, you have passive cooling process, but remember, do not use ice packings because of the risk of injury. Now you have done the therapeutic hypothermia, and now you are going to rewarm the neonate. How should you start rewarming? After 72 hours, we start rewarming slowly, that is, at a rate of 0.5 degrees Celsius per hour. This is the highest risk time for rebound seizures and apnea. So, do not extubate during rewarming. Wait until they are normothermic. That is, the temperature is up to 36.5 degrees centigrade. So, we should start rewarming at 0.5 degrees centigrade per hour. And if the child is intubated, do not extubate till the temperature reaches to 36.5 degrees Celsius. Before cooling era, that is the therapeutic hypothermia period, the death and mortality was up to 60%. But thanks to this cooling process, death disability is decreased up to 40%. So, one point to remember, this is a treatment, not a cure. It reduces the size of the stroke, but it may not erase it. Remember, after the therapeutic hypothermia and rewarming, you should not discharge and forget this baby's need. So, before discharging, you should have MRI. You should also follow this child at 18 to 24 months for neurodevelopmental follow up at 18 to 24 months. You should also have hearing assessment because HIE can damage the cochlea, and also the vision assessment. So you should follow these child for neurodevelopmental, vision assessment, and hearing assessment. We have covered almost all the thing. Let's summarize this lecture. From the start till the end, we have done few things. So to summarize, remember, neonatal encephalopathy is not equivalent to hypoxic-ischemic encephalopathy. You should rule out the mimics. Mimics are metabolic, which includes urea cycle defect, molybdenum cofactor deficiency, infectious meningitis or encephalitis, stroke, SMA. So you should rule out the mimics. Second is the timing. That is the 6-hour window for therapeutic hypothermia. Criteria for cooling. So just pause this video over here and remember or revise criteria by own. That is the gestational age, which is equal to 36 weeks. Second one is weight, which is greater than equal to 1.8 kg. Criteria A, that is the pH or base deficit, pH less than or equal to 7.0, base deficit equal to or greater than 16 millimole. We have a borderline clause over here as well, and the clinical exam criteria, that is the Sarnat exam, which should be for moderate or severe. So for diagnosis, one from the criteria A and either the moderate or the severe one from B. So you should cool these babies, or if you find during your examination that the child is having seizures, you should cool. For the seizures, the drug of choice is phenobarb. The second line is Keppra or fosphenytoin. Imaging, the best time is 5 to 7 day T1 T2 imaging protocol for MRI, and it detects two type of injury, basal ganglia or thalamic, which can lead to motor deficit, or watershed injury, which can lead to cognitive deficit. Safety, you should also watch for PPHN, that is the preductal and postductal oxygen saturation during this process. Now you have complete all the point. I hope this lecture will cover all the major parts what you have required to manage this HIE child. If if you still have any query, you can ask me in the comment box. I hope this lecture is beneficial for you all. This lecture is purely for educational purpose. This message is especially for parents. If you are watching this video, consult your doctor first before any treatment. Inshallah, in the next video, I will cover one more important topic related to neonate. So subscribe my channel, and if you want me to cover any of your topic which you want, comment that as well in the comment box. I will inshallah cover that topic in the next lecture as well. Till next video, Allah Hafiz.